Today on Primary Care, menopause. Studies show that black women are more likely to experience intense symptoms than their white peers.
If a woman is experiencing more like, 20, 30 hot flashes in a day, she's a probably miserable person at that point.
Hello, and welcome to Primary Care. I'm Dr. Lonnie Joe. For many women, menopause comes with its own set of challenges, but for black women, these challenges can be more severe. For instance, African American women are likely to experience more intense symptoms from menopause than most white women. What's worse, these symptoms, particularly hot flashes, increase with age in African American women. Experts say genetic and environmental factors likely play a role, but you don't have to let menopause bring you down. Here to tell us why not is my guest, Dr. Patrice Harold. Dr. Harold is a board-certified obstetrician and gynecologist in private practice at Southfield Obstetrics and Gynecology and is the director of the minimally invasive surgical unit at Hutzel Women's Hospital at the Detroit Medical Center. Dr. Harold, welcome to the program.
Thank you for having me.
So glad to have you. Tell us about menopause, this thing that everybody knows about. Most women are going to experience it sooner or later. What is the definition of menopause?
The definition of menopause is when a woman goes a whole calendar year, 12 months without having a menstrual cycle. It's very simple. So
anybody can arrive at that definition, whether it's the patient, the primary care physician?
Absolutely, yes. So if you see a patient in your practice who hasn't had a cycle in over a year, you can consider her postmenopausal.
Okay. So we understand it comes in stages.
Yes, it does. We have the perimenopause or premenopause, menopause, and this time frame could last for several years. The average age for menopause for American women is around age 51.
So we know that this is important because on the internal medicine side, perimenopausal patient with certain other elements of diagnosis really can be a lead up or set up to heart disease in a woman that can present totally different.
Oh, absolutely. When women start to go through menopause, the hormones fluctuate, so they have less estrogen. We do know that estrogen has a cardioprotective effect by keeping the HDL, which is the good cholesterol, high, and that really helps protect the heart against heart disease.
So all these years of having periods where protection was available, and all of a sudden you reach a stage where the protection begins to wax and wane.
Absolutely. And not only that, as when you get to that age, like 45, 50, not only does your HDL start to go down, but other things, your weight goes up, your probably activity might go down, which actually increases your risk for having cardiovascular disease also.
So these are some of the other signs and symptoms of menopause.
Yes, I used to tell people your metabolism slows down. I think it just stops. So they have to be more active. I'm not saying you have to go run marathons, but you have to keep moving. You have to be doing something every day to keep the calories down, to keep your heart healthy, your bones healthy.
So basically, the kinds of things that we recommend for general population still fits under this category of becoming post-menopausal.
I think actually they're even more important because the lady goes into menopause, that perimenopause, in her healthier state. She's not as symptomatic. She can still have hot flashes and night sweats, but I think the stress that goes along with that is easier to handle because she is active, she's doing some regular exercise, and having a healthier diet can help her go through that time a little bit easier.
So you mentioned it, hot flashes. That's what everybody refers to. What technically is a hot flash?
So a hot flash is an overwhelming sense of heat that usually starts in the chest and rises to the head. You can see women, you might be in a meeting or something, and all of a sudden she looks like she's sweating or diaphoretic. She's probably having a hot flash. They can be triggered for some women, sometimes with stress, caffeine, hot beverages, spicy foods. They can last 2 or 3 minutes and then they subside. But just think, if you get sweaty and then you get cool at that, then you feel clammy, and it just really can alter your daily life activity and your quality of life. So if a woman is experiencing more like 20, 30 hot flashes in a day, she's a probably miserable person at that point.
How would a obstetrician gynecologist approach the treatment for a person having those kinds of symptoms?
Just like any physician, we take a good history and physical, and we ask you, are these bothersome? Is it affecting your quality of life? And then we try to get the patient to kind of see, does anything trigger those hot flashes for you? If so, you want to try to avoid those triggers. Sometimes dressing in layers helps, drinking cold beverages helps, avoiding stress, which is sometimes impossible to do. So we try to get that history, and then having that patient look at that and say, maybe I can do these things. Now, if all else fails, the only known treatment is to do, we call it, hormone replacement therapy, is to help hot flashes.
You mean as opposed to all of our patients having a pill book and internet access, you're saying that even the home remedies that some people believe in, the only real treatment is hormonal replacement?
The only treatment that has scientific data that does work is a hormone therapy. It supports it, right? Is there a placebo effect to some of these things? It might be, and if it works for you, that is fine. If you can take your, soy, or you can take your black cohosh, dan quai, all that kind of stuff, it works for you, then let it work for you. But when we look at the science behind that, we really don't have any data that suggests that those remedies do help. And if they do help, some of the bioidenticals, we don't have enough data to say, is it causing harm other places either. So even with hormone replacement therapy, we have to be very careful, because we can increase that woman's risk of developing breast cancer, or if she has a uterus and takes estrogen without progesterone, it can increase the risk of developing uterine cancer. So if you're taking a bioidentical or some type of natural product that's helping with your hot flashes, is it causing harm somewhere else?
Do we, in the primary care setting or otherwise, do we really need to be measuring hormonal levels on patients who are entering into or have entered into menopause?
Measuring a level is just a one-time level you get, and it's not really, they're not telling you anything about that patient.
Empty information.
It is. Her symptoms are telling you about her. If she's complaining of, the hot flashes, the night sweats, the vaginal dryness, you treat those symptoms. We don't treat blood levels when it comes to menopause. So,
granted, this might be a little bit sensitive for some people, but the emotional aspect of menopause, we even see an increase in depressive states sometime in menopause. How should we be addressing that in these patients?
Again, getting that good history and talking to that patient, and if it's affecting her quality of life, if she already had some history of some depression, this could exacerbate those symptoms. So, talking to her, seeing how is this bothering her? Is it affecting her relationship with her partner? Is it affecting her, work status? And a lot of women, some women actually are so distraught with the symptoms of menopause, they can't sleep, they can't think, they can't concentrate, and that can exacerbate any of the depressive symptoms they were having even prior to menopause.
Have you seen very severe cases of depression associated, and obviously more than likely, in some cases, may have been a pre-existing condition?
And I've been practicing for a while, so I've had several patients with some depression, and actually, so I work with them. I try to help their symptoms, and I actually work with a therapist too to help them with their depression. Some medication for menopause that is known to affect is like some of the SSRIs, like Paxil. Sometimes using that for a woman to help with her symptoms can actually be working in two areas, help with some anxiety, depression, along with her hot flashes.
Two birds with one stone.
Absolutely.
Good. We're up against a break. We'll be right back with more of primary care and our discussion on menopause right after this.
We women sure know a lot of numbers by heart. But do you know the most critical numbers for your heart health? That knowledge could save your life. Do you know your numbers? Talk to your healthcare provider today to learn your health numbers. Your heart depends on it.
Welcome back. We're here with our guest, Dr. Patrice Harold, Director of the Minimally Invasive Unit at Hutzel Hospital in Detroit. Dr. Harold, the relationship between menopause and fibroid uterus, can you touch on that for us and help us understand what we're dealing with there?
African American women are known to be a high risk for having fibroid uteri. Actually, at one point we're saying 50%. Now some new data says 80% of us have them.
80%?
80% have them, but most are asymptomatic. Okay, so they have no symptoms, they don't know. We can examine it, they can fibroids. But after menopause, usually fibroids would tend to shrink. So if I can get my patient who has fibroids, who is having symptoms, if I can continue to treat her symptoms to get her to menopause, then once she becomes postmenopausal, she's not having cycles anymore, which is one of the biggest symptoms is heavy bleeding, or pelvic pain and pressure, but they will shrink after menopause. The majority of them will shrink after menopause. If they grow up to menopause, that could be a sign of uterine cancer.
But potentially a reduction in the need for surgery.
Absolutely, yes.
So what about osteoporosis?
Osteoporosis is the thinning of the bones, and it starts to occur actually before menopause, and you peaks at menopause and afterwards. One thing now, we don't really do bone densities until about 5 years postmenopausal, but the problem starts earlier. So I always try to encourage my patients to have the increase in calcium intake, about 1,000 milligrams a day with vitamin D and some weight-bearing exercise to help protect their bones. Now, if they have a family history of osteoporosis, they're at higher risk. Women who smoke are at a higher risk. Women with thyroid disease or women who have been on steroids are higher risk for having osteoporosis. So those women, I try to get a bone density a little bit earlier because some of the bisphosphonates can help prevent go from osteopenia to osteoporosis. So this is something we can do to actually help preserve her bone health.
Right. I'm always looking out for that little innocent fracture in a perimenopausal female that with the least little activity shows up and you say, oh my goodness, we should have probably looked a little bit earlier for osteoporosis in that patient.
Yeah, absolutely, absolutely. Especially someone who had asthma, who's been on steroids on and off for her life.
Correct.
These are the women I get kind of concerned about too. Or women with poor nutrition,
right.
Poor calcium intake.
So all of us have experienced someone, or we know someone who has experienced this, that late baby coming along. The risk of getting pregnant in the first year of being perimenopausal.
So a woman can still conceive until she goes an entire year without having a cycle. So these are the ones I tell my patients who are not only birth control, never had a tubal ligation, having those irregular cycles. I go, what are you using for birth control? Oh, her odds are not great, but she can still happen. And we all know someone who has happened too.
The odds aren't zero.
They're not zero, no. So they're not zero. Then if it's something you don't want, then you need to protect yourself.
So the caution is there that everybody should be aware of. You still need to have the awareness that pregnancy is possible.
Absolutely.
And if you get pregnant, it's not like you didn't know.
That's what I tell them. Until you go a whole year, then there's that possibility.
Many patients, Patrice, don't realize all of the changes that their body go through that may be related to menopause. Talk about some of those associated issues like vaginal dryness, which is very, very common at this stage. Talk about some of those associated issues. Vaginal
dryness is a very, very big problem for women going through menopause. Even in perimenopause, women can start experiencing vaginal dryness. The vaginal mucosa is hormone dependent. So when the hormones decrease, the vaginal lining becomes very thin. We lose the rugae, which are the structure of the vagina becomes kind of narrow and straight. The pH changes, causes more irritation and discharge. And because of the vagina in itself is a supporting structure for the bladder, the rectum, when we could have problems with incontinence, urinary incontinence, and even fecal incontinence, which is sometimes they're embarrassed to talk about. Painful sex, which is something else. Here's a time, especially you're in a relationship and your partner wants to have intercourse and you can't because it's so uncomfortable. So these are the things that we want to talk with women before they start to happen, because there's some education we can provide them to decrease the symptoms of that and to help protect their pelvic floor, so they don't have what's called prolapse when the things start to drop and fall.
The onus is on the side of the provider, though, to actually bring these issues up, because like you say, some people are really embarrassed to talk about things like fecal incontinence or vaginal dryness. So the onus is on us to make sure that that education portion takes place by way of just asking questions.
You have to ask the question, because a lot of times the patient won't bring that up to you because she is embarrassed. I mean, most gynecologists, on our standard interview, we always say, are you having any problems with any painful intercourse? Do you have any problems with losing your urine or your stool if you cough or sneeze? Do you have any discomfort in the vaginal area?
So this is something that is well known. We just have not been able to make the connection to get the desired result, which is basically, like in most other disease states, an educated patient and an aware patient that communicates properly with their provider.
Absolutely. And some people think it's commonplace. We see commercials for the poise pads and these different things to help with the incontinence. And even now they look like pretty underwear. We can prevent that from happening if we are educated prior to the problem. We can actually prevent that from happening.
So what kind of treatments are there available for things like urinary incontinence and painful urination for patients in this category?
So once that patient has the symptoms of incontinence, we want to do a good history and physical to make sure it's just not a structural problem, because there could be a neurological problem along with urinary incontinence. Once we make that decision, if it's just the vaginal dryness, there's different actually, vaginal hormone therapy has been known to help improve incontinence. There are other moisturizers for someone who can't really go on hormone therapy. There are vaginal moisturizers. There's exercises, Kegel exercises. I tell women, every time you stop at a light, do your Kegel exercises to help keep that vaginal muscle stronger. Avoiding stresses. Going to the grocery store, bringing all those groceries into your home in both arms, put pressure on that pelvic floor, causing that pelvic floor to just drop a little bit and weaken. Lifting those cases of water, another big thing. We go to the grocery store, we get a case of water, we carry into the house. All that little lifestyle changes that can help to decrease the risk of having some problems in the future.
Since we're talking about these things, let's just expand it a little bit here. Patient's libido. I think this should be a discussion also.
Yes.
We got away with it with the male factor, before the introduction of the PD5 inhibitors. We didn't, ED was a minor problem for men, but then when there was a medication available, everybody was seeking the drug, okay? So here again, we should be talking about decreased libido in females who are entering into menopause.
Right. So when we go through menopause, not only do our body stop making estrogen, our ovaries made a little bit of testosterone. That kind of helped us with our libido. And going to estrogen and everything helped the vaginal area it was healthier. So when the vaginal area becomes dry, if sex is uncomfortable, our testosterone levels go down lower. It's not comfortable. If it hurts, we don't want to engage in that. And once we have painful intercourse, it's really hard to enjoy that. So we have to take the pain away for the patients. And we do have preparations that can help. Sometimes it can get too far gone that it's not just I can help, but sometimes I have to use a therapist at the same time to get that patient to be able to relax and to know that this is not going to help her mental state improve her vaginal health also.
We now have viagra for women, but it has to be used properly, and a lot of times we're too late.
Right, and the preparation for women, it's indicated for premenopausal women, okay? And when you look at the studies, it only improved sexual desire or sexual pleasure, one more pleasing episode a month. And it had a lot of side effects with it. You can't drink any alcohol, so that can be, problematic. But I think it opened the door because we didn't have anything at all. And once we get that one drug that got through the FDA testing, other drugs are on the market right now that are still going through those stages that, to get approved. And I think it has opened the door. So hopefully in the future, we can have something that doesn't have a lot of side effects. Some things work, but they cause cancer. Who wants to accept that it's going to cause cancer or cause hair growth or acne or cardiovascular problems? Right. So you don't want to offset something that has more risk than benefit.
Dr. Harold, we're up against a break. We'll be right back with more of Primary Care.
It's been said that knowledge is power. So learn the warning signs of uterine cancer, like bleeding that's not normal for you, or unusual pelvic pain or pressure. Knowing is powerful, maybe even life-saving.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become 1 in a million.
We're back with Dr. Patrice Harold, Director of the Minimally Invasive Surgery Institute at Hutzel Women's Hospital. Patrice, tell us about how we advise women about gynecologic surgery as it relates to the diseases surrounding this state of menopause. Should we be actually more on the primary care side, supporting the body of knowledge or adhering to the wishes of the patient, or basically just saying, listen, you need an expert opinion on this? Call a gynecologist that needs to evaluate you and advise you on this, because some of the recommendations are all over the map, and a lot of it is because of what we read in the lay press and what some of the non-scientific approaches have been and the common opinions that people have. My impression is that we need to narrow that scope some so that we can get better outcomes and give people better information to make choices.
And when we talk about GYN surgery, you want to go to the GYN experts, the gynecologists. You know, we have patients who come in and they tell me they did that research. I go, they done Dr. Google. I go, okay. And I actually went to school and I've been practicing for 30 years. And so when I approach my patient who needs surgery, either for fibroids, for urinary incontinence, we look at all the aspects. We try to do a non-surgical approach first. We treat symptoms. So if a patient has fibroids, she's having heavy bleeding, she's having pain and pressure, let me try to, you can, instead for the pain and pressure, we can do hormone therapy to help some of the bleeding. But when all else fails, you might still need surgery. If you're getting a transfusion every 2 or 3 months, this is not working. So, and we can do things minimally invasive now too, to help decrease the risk of any infection and bleeding with your surgical procedures. But we work with our patients and we try to find a common ground. We can say, we'll try this. If this doesn't work, we might have to go for surgical procedures at that point.
You know, some of the worst, as an internist, some of the worst anemias that I've seen presented in patients sometimes have been because of uterine disease.
Yes. We do alternatives though too. So not just always hysterectomies. We do a procedure called an endometrial ablation. We can actually destroy the lining of the uterus. With 65% of those patients might not have periods anymore. The other 35 will have less. And if she's in that perimenopausal period, it might just be enough to get her to menopause where she can avoid having a more advanced surgical procedure. Or using Mirena IUDs, which is it's FDA approved to treat heavy bleeding. It's good for 5 years. Put an IUD inside her uterus, and someone are amenorrheic for that entire 5 years, or have a lot less bleeding in order to build up their iron levels in their hemoglobin.
Talk a little bit about so-called uterine sparing surgery. We see people who have fibroids who still may want to get pregnant and have a child in the future. What's the approach to those patients?
Not just to have pregnant, but some of them don't want to lose their uterus, and we respect that. You know, this is your body part, and you know, you're blessed with this. So if I can do a procedure and you would prefer me to spare your uterus, there are things we can do called a myomectomy. We just remove the fibroids and close up the space. Now those are some more advanced procedures because the women will bleed a lot with that one. They'll have a high risk for infection. And even with a myomectomy, if I go in there and remove every fibroid you have, there's still like a 25% chance you're going to develop more. Now, if you're 30 years old, you have another 20-something years, you know, of still menstruating when you can develop more fibroids. So it's when I do that, it's usually so women can have children. Boy, like I said, some of them just don't want to lose their uterus. We do myomectomies.
Let's shift gears for a second here. Hormone replacement therapy, HRT, big topic, has been for years. A lot of controversy on who should get it and how they should get it or whether they should take it at all. What is the place for hormone replacement therapy in the modern era of treatment?
The only FDA indication to treat hormone replacement therapy is to treat the hot flashes and the vaginal dryness. So the patient, like I said, if her quality of life is really being disturbed and she's tried everything else, then I will offer her hormone therapy. If she has a uterus, she cannot take estrogen alone because that can increase her chance of developing uterine cancer. So we have to give it along with progesterone. So the estrogen-progesterone combination for a woman, the lowest dose for the shortest amount of time is what I usually do.
So the benefits are clear.
Yeah, definitely. It definitely can help with the hot flashes.
And outside of you know, the imbalance that is the result of using it, are there any other side effects or negative issues or concerns that patients should have?
When we look at the WHI, the Women's Health Initiative, we do know when they took the combination of estrogen and progesterone, those women were at increased risk of having cardiovascular disease and thromboembolic problems and breast cancer. So these are the issues we have to address with them. Tell them these are the risks that you may incur. So make sure you're getting your mammograms done every year. Look at her look at her liver profile. If she has high cholesterol, she might be someone who might not want to go on hormone replacement therapy. Or look, if she had any history of clots, we probably wouldn't want to put her on hormone replacement therapy either.
So the history again becomes important.
Absolutely.
And actually the history as it relates to the discussion with the patient and making a decision as to whether or not use HRT.
Absolutely, yes.
So where's the support coming from women in this arena? You know, it's kind of hard to talk about the female alone without talking about the support mechanism that they have, the spouse, the significant other. How is this affecting them? I mean, are we actually getting to the point that we can provide support for the husband or the couple as a whole? Have we moved to that arena with any speed that really helps patients get through this phase?
I think we have, especially as gynecologists. When I talk to my patient, I ask her, what problems are bothering you, and are they bothering you in your relationships? Are they bleeding?
How does your husband
feel about that too? And husbands come in too. They say, tell her this, tell her that. Like you could tell me too. So I talk with husbands all the time, and then I ask them, how is this affecting your relationship? And we discuss that. So sometimes working with that unit, as opposed to just two separate people, that really can guide that patient to what's going to be best for her and her relationship with her partner.
Well, it's good to hear that the husbands have graduated from waiting in the waiting room for the wife to come out and relay the subject. It's a group discussion, and we're making progress. That's very good to hear. Thank you so much for joining us today. This has been very informative, and we shall do it again.
All right, thank you for having me.
Good. We've been talking with Dr. Patrice Harold, Director of the Minimally Invasive Surgery at Hutzel Women's Hospital and in private practice at Southville Obstetrics and Gynecology. Stay where you are. We'll be right back with some final thoughts right after this.
You listen when your body says, I'm tired, or I'm hungry. What if your body said something else might be wrong? Gynecologic cancers, cervical, ovarian, and uterine cancers have symptoms. So pay attention. If your body says something may be wrong, please listen. If it goes on for 2 weeks, see a doctor. It may be nothing, but find out, learn the symptoms, get the inside knowledge about gynecologic cancers.
My final thoughts. Menopause, a condition that will affect every female, whether it's early, late, or medically induced. Therefore, we recommend that you discuss this condition with your caregiver and talk about treatment and treatment options. Why? Because they can be very beneficial and improve your quality of life. For Primary Care, I'm Dr. Lonnie Joe.